Hello and welcome to day 2 of ASEP's Best Practices in NSCLC Biomarker Testing Virtual Summit. Today's event is focused on ordering and turnaround time. My name's Dara Oken, and I'm a learning experience designer at ASEP, and I will be facilitating today's session. This session is developed through commercial sponsorship from Genentech. This ASEP Genentech initiative is aimed to support anatomic pathology managers and their teams by building community and providing effective resourcing to drive biomarker testing continuous quality improvement on behalf of patients. Please note that this video conference is being recorded, and by participating, you are agreeing that ASEP may use the recording of your image and statements on ASEP's website. Okay, before we jump into our session, let's take a moment for introductions. If you would, please type in the chat your name, your title, and institution. Great. As you continue doing introductions, we'll move on here. Yesterday, we did a quick recap as the virtual summit follows a 4-part video conference series held this past year, highlighting best practices throughout the workflow. And again, videos for each session, as well as recorded highlights, are accessible through links at the ASEP Resource Hub and our Biomarker Testing Facebook group. So the goal of the summit is to narrow our focus on topics video conference participants have identified as challenges in the lab. Yesterday, we addressed tissue acquisition and processing. Today, we'll address obstacles and opportunities in the areas of ordering and turnaround time. And again, we'll explore actionable solutions to common challenges through examples presented by those who've tackled similar challenges in their own labs. The action plan has been our roadmap to support AP lab managers in making sustainable quality improvements in the lab. And as best practices are shared today, we'll explore action-oriented solutions that you may choose to adapt as the basis for your own action plan. Similar to yesterday, we will begin with sharing an approach to lab quality improvements, this time in the area of ordering and turnaround time. We'll have a brief Q&A following the presentation, and then we will shift into a facilitated discussion to highlight bright spots from the field, additional examples of impactful quality improvements made in the lab. And this working session discussion will include a solutions-oriented framework, leading you towards implementing action steps. After a short break, we will close with our multidisciplinary panel discussion to explore how teams work through making key decisions. So a few final reminders before we start. Please keep your microphones on mute until you raise your hand and are called on to speak during question times. And please do not share any protected health information or personally identifiable information about patients. So now let's welcome Carla Valencia, Pathology Laboratory Manager at UT MD Anderson Cancer Center, to share with us One Lab's approach to quality improvements in ordering and turnaround time. I'll turn it over to Ms. Valencia to begin.
Thank you everyone for joining. It's my pleasure to present today, Improving Biomarker Testing Turnaround Time. So we begin by going over why are biomarkers so important. Biomarkers are very important because they serve as a diagnostic tool. They offer opportunities for new treatment. They also allow for patients to be eligible and enroll into clinical trials. They aid in prevention and assessment and management of care. So why are biomarker workflows so complex? They're complex due to the nature of the steps a pathology case undergoes, the availability of a sample in a timely manner, the additional workloads that it increases for laboratory staff and for pathologists, and also the high demand from the clinics and clinicians for expected or expedited turnaround time. Where do we begin? We begin by addressing the areas with the highest impact to the operation, which in this case is the retrieval of material, the delay in results, and reducing foot traffic. Therefore, we have implemented 3 of the following improvements. For the retrieval availability of a specimen, we've introduced a runner, which I will further elaborate. We've established fast-track testing, and then also future state will adapt to a fully digital workflow to reduce the travel time of slides and materials. I will pause to provide a high-level view of our current AP biomarker workflow. At the very top, you will see that the clinical team places an order for a series of biomarkers. This can include IHC, MDL, FISH, and other approved sendouts. From here, the pathology expediters receives the orders and begins the biomarker process. Further down, the pathologist reviews all the material and provides feedback regarding the tumor percentage and quality of specimen. And lastly, it ends with the pathology expediters coordinating and delivering the materials to his designated lab. Embedded within this workflow is a unique position, which is the pathology expediters. The pathology expediters assist in biomarker processing and provide support to our clinicians and pathologists, nurses, and outreach centers. They analyze and interpret internal and external path reports to determine the appropriate subspecialty service to process the biomarker or protocol for diagnostic review. They check selected information after the pathologist reviews for biomarkers or after the initial cases accession. This is mostly applies to prospective cases and for diagnostic review. They accurately document selected specimen and other details for biomarker testing. And lastly, they coordinate and place laboratory orders to ensure pathology materials are delivered to his designated testing lab. Now, we will come back to roadblock number 1, which is the retrieval and availability of cases and specimens. In order to improve this, we introduced a runner to identify archive cases on new orders and expedite the retrieval of material. This has significantly improved the turnaround time in delivering slides and materials to IHC, cytogenetics, and MDL. Addressing roadblock number 2, which is delay in results. We introduced fast-track testing for some subspecialties depending on the diagnosis. This involved coordinating clinicians and pathologists, standardizing operating procedures with the clinics and pathologists, and also performing a 3-month pilot to monitor roadblocks and identify areas in need of improvement. After 12 months, we're currently on case 284, and our turnaround time has significantly improved. I will now discuss the pilot study for AP biomarkers fast-track cases. This one's geared towards neuro-oncology and neuropathology. Neuro-oncology will notify the neuropathologist of a prospective specimen collection, and place a biomarker order. The pathologist identifies cases with the following diagnosis listed here. The pathologist reviews the case and performs necessary IHC testing and prepares slides to submit for molecular testing. Our goal is to parallel the same workflow for our NSCLC patients. These are the fast-track methods that we calculated and monitored for the past 12 months. If you can see the red font, this is the improvement that we collected and are not able to report. Fast-track testing has reduced the turnaround time for STGA DNA by 7.65 days, for STGA fusion by 11.6 days, and for MGMT by 14.38 days. I would like to pause for a moment to provide definitions for this specific workflow. Fast track is meaning creating a customized workflow where the pathologist is driving the biomarker process, therefore bypassing the established biomarker workflow that is primarily driven at this time by pathology expediters. Reflex testing is when a pathologist initiates a series of tests based on a diagnosis. For example, the diagnosis of NSCLC gets reflexed with a PD-L1 22C3. And this is the fast track workflow that we've been able to establish after 12 months for the neuropathology cases. We are now in the process of conducting a pilot study on thoracic pathology cases as well. This is the proposed procedure or workflow that we're trying to establish. The IR and the clinical team will place an order on prospective NSCLC diagnosis for patients with this diagnosis. Pathologist is notified and proceeds to order the reflex testing of PD-L1 22C3, and also includes his original diagnosis. The clinical team is able to view the results within 24 hours and begin treatment. The pathologist will also proceed in preparing additional materials for any molecular tests that they choose to reflex or that the clinic has recommended. And this study is currently underway. Lastly, we will address roadblock number 3, which is reducing the foot traffic and expedite retrieval of materials by implementing a fully digital histology and pathology workflows. Current state, we're only scanning the primary tumor slides for each patient or each case. Future state, we want to scan every case and slide into the patient's chart. In order to be successful in implementing a fully digital histology workflow, we will need to place digital scanners within every laboratory for the technicians to load the slides once they come off the stainers. This would include all slides, H&Es, IHCs, and special stain. By providing digital scanners in all lab areas, we will provide the following improvements. 1, it will reduce the amount of time of retrieval of materials. And 2, the pathologists reviewing the cases for biomarkers can now do this virtually. This includes marking and identifying tumor percentages on digital slides. And this is our proposed digital pathology AP biomarker workflow. We hope, if we can recall the very first slide, I believe is the 4th slide, it's the current process that we have now, which actually took 2 slides. In the future, we hope to start reducing it and eventually lead to this proposed workflow here, which is more simple. It will really aid in expediting cases, and it will aid in having increasing turnaround time for results and enrollment of clinical trials and treatment for patients. I would like to thank my colleagues and faculty for their contribution to this presentation. And this concludes my presentation, and I thank you all for your attention and open to any questions that you may have.
Wonderful. Thank you so much, Ms. Valencia. Yeah, we'll pause here for questions or comments. If you would like to share, please click reactions near the bottom of your screen and select raise hand so we can call on you. We do have a prepared question here. What are some biomarker challenges your institution is facing?
Well, there's many, but I guess if we could rank them in order of priority would be, especially since we are a cancer institution, there's always new enrollments, new drugs that new treatment plans that we can offer patients. However, sometimes undergoing clinical trials or establishing those, whether it be IHC markers or molecular studies, sometimes it's challenging just due to all of the availability of enrolling additional patients or going a different route. So it would be resources, it would be trying to provide that care for the patients, but not having everything in place with regulations and regulatory agencies, I would say would be best. Another challenge would be the increased amount of orders that we're receiving daily. I don't know if other hospitals have experienced this, but we are having a big interest in patients driving their care. They're researching, and then now they're requesting a lot of genetic testing and genetic treatment. So in order to keep up with the demand from the clinics and the patients, sometimes that might be a challenge with staffing. And then also coordination between what we can do from the clinics downstream to the laboratories.
Okay, thank you. I see a question in the chat. Are your orders placed through the EMR, or are they performed on site, or are they sent to a reference lab?
The majority of our tests are performed at MD Anderson. We do have some selected, it's mostly genetic panels that are not currently offered and we're currently validating that we do send out, but we do prefer to do all of our testing in-house.
Okay, great. And follow-up question here. How did your organization determine what biomarkers are ordered by your pathologists?
I'm sorry, can you repeat the question one more time?
It is, how did your organization determine what biomarkers are ordered by your pathologists?
I know some are recommendations, but depending on diagnosis, some are regulatory, therefore driven by the FDA. They're recommended for perspective or predictive markers. So that's how I believe the majority of them are paired with the pathologist. We also do have a very extensive amount of, especially IHC, that we do offer already. I don't know if I answered that.
I think you
correctly.
did, unless, Lynette, do you want to ask on the mic or follow up?
You know what? Let's save it for discussion. But yes, that answered part of it, but now I've got to follow up. But we'll just take that one to the discussion board.
Which is great. And we're ahead of schedule, but let's make this a robust discussion and let's move that direction. So I just want to say thank you so much, Ms. Valencia, for a fantastic presentation. And we're going to dig into that first. We're thrilled to have Lynette Pino facilitating this conversation discussion session with Carla Valencia joining in conversation, and hopefully with input from all of you joining us today who have experience in the lab to share. So in this discussion activity, we will revisit topics presented by Carla Valencia and highlight some other bright spots from the field, examples of quality improvements with significant impact in the lab. We'll also have solutions-oriented discussion, steps you might consider in your lab. Lynette, if you'd like to share your screen, we can begin.
Great. Thanks so much, Dara. Appreciate it. And thanks to everybody for participating today. I just have to say that I've just really been enjoying all the work that we've done with this series and also with the summit. And Carla, too, it's so fun to see other AP lab managers and how they're managing this workflow. And the same as Gazelle yesterday, it's really great to be able to make those connections and see how everybody's doing the work and be able to share our pain points and some of the best practices and just learn from each other. So thanks for a great presentation. It was really a lot of fun. So here we are. I'm going to bring everybody back to that welcome. And I know that Dara already talked through this a little bit, so we'll just have at it. If you've never worked on a mural board before, this is your chance. It's a fun way for us to do some interactive work. We're not all in a conference room together with Post-it notes, but we can still do this virtually, and it's kind of a fun technology that I've been learning to use, and we're going to use today to generate some discussion. So there is a link in the chat that you can grab and open up. At times I may summon you back or pull you back to the board that we're working on so you can see what we're doing, but go ahead and open that up. If you're not comfortable with that, you can go ahead and just put your answers in the chat, and then Dara and some of our producers in the background will help us populate the board on your behalf. So 2 options to participate today. So with that, here's our kind of little tips and tricks. It's really easy. You can navigate it a little bit like Google Maps. You can zoom in and out using your mouse or your keyboard. You can also double click to create a Post-it note, just like I have here. You can drag it to make it bigger or smaller. And then you can type things in like hello, or your name, or any of those other questions that we're going to be asking. And if you double click or if you drag on your Post-it note, you can move it to different parts of the board. So with that, we will bring everyone here to the discussion board, or the introduction board. And we have Post-it notes already populated here for all of you. So if you would like to go ahead and take a Post-it note and put your name in it, or maybe even tell us where you're from. All right, so everyone is populating the board, so thank you for doing that, or trying to. I can see that, so thank you for filling in. All right, so I'm going to go ahead and move us to the next part of the board, but the first thing we want to just talk about here in our breakout is some of the things that Carla mentioned in her great presentation regarding turnaround time challenges at MD Anderson and all the work that she's done. I also just want to really compliment you, Carla, on those workflows. I know you're trying to streamline them and make them a little bit more, well, streamlined, so to speak, but they're just really great because I think you've got some really great examples of just kind of every step in the process and every place where you can find improvement, or you have movement between the samples and your staff, and it really gives you an idea of like how complex the work can be and where you can go for improvement. So just really, really great to see those slides.
Thank
So
you.
yeah, you're welcome. One of the things that you had talked about was optimizing the turnaround time. That was the main thing we talked about today in your 3 improvements. And I'm also wondering what others might have thought. I mean, if you think about the workflows in your own experience, what are some other alternative solutions to workflow issues or problems that come up in the non-small cell lung cancer workflows in your organizations? I can start with a post-it here and just share that in our experience, where I think we might have turnaround time gains is in what you were talking about, Carla, and in having our pathologists place those orders kind of as a standing reflex to the diagnosis. We don't do that currently. So right now our oncologist places the order. So I can move from oncology placing orders to pathology.
Or just even establishing, like I mentioned within the presentation, sometimes it is a little challenging just due to the nature of how busy they are in the clinic, and then also faculty being on service. But coordinating and having a procedure, an agreement between the clinics and the pathologists is very advantageous to the workflow. There's a lot of steps that can be shaved off that are currently occurring, that the labs are currently doing, because when they're collaborating, they're sort of highlighting that patient and discussing that patient's treatment at a higher level, right? The laboratory is not involved. Therefore, like, I'm sure you've received orders where the patient does not qualify for some of those orders that the oncology team has placed. Therefore, I don't know what your workflow is, but maybe your staff goes ahead and grabs it and starts working on it, versus when the pathologist and the oncologist coordinate the care for that patient, they immediately roll out if this patient is not, for example, an NSCLC, and either abort, nobody has lost any time cutting and reviewing those materials, and then they just take on another approach for that patient.
Yeah, so you bring up a really good point. I think one of the things that we see that's in that vein is previously, so we have a standing order that's set up, so that has helped a little bit. We have an order set now that they have agreed to, our oncology teams have agreed to use, following NCCN guidelines for biomarker testing. But prior to that, the oncologists were basically placing an order, like kind of almost through an email, and then we were placing orders. We do send out, so we're placing it through a portal. And in doing that, sometimes, especially in the early beginnings, some oncologists weren't even really clear of what they were ordering. They knew they wanted a MET, but what MET do they want? And what was interesting in my experience was that we were standardizing the ordering patterns between 2 oncology teams within our organization. And one was using MET with exon skipping and one was not. And there was just kind of this like aha moment of, oh, like, okay, we got to get all on the same page. So I know that was really challenging for our path support staff in the beginning, because they were trying to field all these questions from oncologists that were kind of new to it. Obviously it's a lot better now. The guidelines have been around for a while, and especially with the order sets, I think that's helped. But really trying to help folks with that ordering process when the biomarkers themselves can sometimes be confusing.
No, that's definitely true. There is sometimes our oncology team would often use their nurses or PAs to place orders also on behalf of them, and there is that confusion there as well.
We're going to go on to the next piece of this. So we have 2 videos that we're going to be watching today, and we're calling those bright spots. And they're little vignettes that we've reached out to some other leaders in the field that deal with some of the same issues that we've been talking about today. And they have described for us some problems that they've come across and some of the solutions they've had. So the first one is Elba Vidal. She's the anatomic pathology manager from the University of Maryland Medical Center. And she is addressing the problem of lab ordering and turnaround time and how to allocate resources to the ordering role, kind of similar to what we were just talking about, as well as the necessity of educating the histology department, which is what you were talking about, Carla. So I think this is a great segue. So if you could play the video for us. Thanks.
We noticed in our lab that we have issues with ordering process. We also find out that we needed a person assigned to this job pretty much full time. And we also noticed that the histology department needed more understanding of why we were doing this and why we were needed so much. We encountered obstacles in our LIS system. It was not kind of user-friendly for the doctors to understand how to put the correct ordering when they needed a special testing. That is not something that the laboratory do in a daily basis, and the understanding that these are send-out tests. And then it was kind of a learning process how to teach them how to do those ordering. But then we also have some issues with completely have a person just doing this task. We have a person handling those send-outs, but also they were doing other tasks at the same time. When we finally get to the understanding that we needed that person just for send-outs, I think that alleviates a lot. And also in histology then, it was difficult to explain to the staff why this was so important, and they needed to prioritize that job over other routines done in the daily basis in the lab. To solve these problems, we start with training doctors first in the ordering process, how to make the orders in the system, in the LIS. I can say that still we have doctors that don't know how to do it, but now we have a better communication with the physicians and the pathologists and the send-out department, and explaining to them what they need to do in the LIS system for us to get those orders as soon as possible. Also, we encounter that sometimes in tumor boards or in other activities that they are getting together between the pathologists and the physicians, they are requesting those extra testing. And then the pathologists come back to the lab, they put orders for those requesting tests. And then we improve that it's going out faster. Instead of waiting for them to put the orders, then the pathologists are putting the orders. Also, like I say, the communication process improved completely in general. And then we also receive emails asking us questions that how to put orders, or if they need this, what they need to do, things like that. We also have a special testing, a special request that they require other forms to be filled out. That definitely has improved a lot and is making our work easier. Then we also have the person in the send-out department is stable here. And pretty much the entire day, the person is just handling these orders, this communication, phone calls, ask questions. And if you have the ability to hire a person just to get that work done, it would expedite everything for your lab. And then in histology, I think it was just a learning process for them, why this was so important to understand that what we normally do or routine daily job, it will stay there, but this is something that we need to send out to other labs to be processed, and they needed to get that done quickly because the other testing take a long period of time, and the most we take here at our lab processing, the more it will take in the other lab to get processed, and then the longer it will take to the patient to get results to start treatment. After you explain to them all those points and get it to understand that this has a priority for us, they work to get a workflow better and a way that for all of us, the send-out department, the doctors and histology, working together to get it as fast as we can out of our lab. I think everything is in less than a day here in our lab. Everything is processed from the time that we receive our order to the time that the slides are out of our door. But in less than a day, we have everything done. If you can create like a Excel table or something that will help you for this test, you need 25 slides. For this test, you need 5 slides. That expedite the process. And then what we did with that is to put certain tests that are used more frequently in our lab. We add them to the LIS system that we automatically order them, and everything that we need for that testing came out in once. We have everything incorporated in our LIS system, and then histology receive a report, a printout of how much they need to cut, if it's 5 micron, if it's 7 micron, whatever they need. Sometimes they need scroll or anything, a special procedure. All those more common tests, we have them in a way that they are automatically ordered, and then that expedite the process. After we have that added to our system, definitely that was a different improvement.
So that was a really interesting presentation that we just heard from Elba, and I thought it was really great because she gives us several different things to think about when we come back to the board here. There was a couple things that I wrote down that just kind of pinged my thoughts about her challenges or her problems. But I'm wondering, Carla, what was the one thing that stuck out to you the most in her presentation?
I think one streamline, and if you look at the streamline upstream and downstream, it would be communication. I think that was the one thing that I picked up on. It would be communication and clear understanding, like what is your goal here? So that's one of the things that really stuck out to me. Because it seems like from there, once you communicate and establish something and get a better understanding of what you're trying to achieve, then you can align what you need to get to be successful. So like she mentioned send outs, and that the laboratory was confused, and then maybe who was placing the order, I guess they knew what they wanted, but then downstream, the communication was fuzzy. So I could see how that, and it happens, especially in laboratories. It's like the action is upstream, but downstream, it's not so clear, but just kind of looping everybody back in, getting everyone on the same page, letting them know what's going on. And then she also talked about allocating staff solely dedicated to addressing and taking care of those send outs has been a big improvement in the operation.
Yeah, that was a big one for me too. I think, there's a lot of kind of conversations that we've had, even just through this series, about dedicated ideas of someone who's just dedicated in the laboratory, kind of almost like a navigator who would help us work through some of those questions we were just talking about, as far as like who helps with the questions that oncology has placing. She mentioned that as well, as far as kind of confusions with orders coming in. And then just also like the send outs. I know that our team, she was mentioning that in less than a day, she's getting all of her cases out. And I think that's amazing. We've actually tried to work that benchmark too. That is one thing that we have been trying to look at and measure. And I think it's been challenging for our team, just because we have so many different send outs coming in now in a way that we never did before, just not just non-small cell lung cancer, but other tests too, right? Or other cancers or abnormalities. So that is definitely a workflow that has been impacted. I think the other thing that she talked about today that I thought was very interesting was the idea of kind of that reframing the mindset in histology. That was brought up yesterday in Gazzo's talk as well, where it's, we used to be just like Monday through Friday, we get in at 4 o'clock in the morning, we cut all our slides and everybody goes home at 2 or 3, right? And now it's where, well, we have all, these processors, retorts, and we can process things more first in, first out, not quite completely first in, first out, but in smaller batches, right? And so how does that look? And today, as Elba's talking, she's saying, well, we really have to think about this. It's not just kind of like, we're just going to go along and cut our slides and go out. There's certain samples now that really do have to take precedence. And how does how do we work those into the workflow and setting those protocols, as she talked about, having those preset protocols when different samples are coming into the lab, so you know upfront. Carla and I were kind of talking offline before we started, and we are on the same LIS system, and that's one of the things, at least in our experience, we've used really well, is being able to set up those protocols so when they're coming in, the accession is a lot easier, and it does help with things like this for biomarker testing as well.
Also, I guess to chime in, Lynette, we also took advantage of it by limiting. So what I don't know if MD Anderson, and it's sort of structured a little unique, but we have clinics that have some specialties, and so we were finding that certain order sets that were created, for example, like the GI group, right, or the thoracic team had set up a standardized set of tests depending on diagnosis, that the GI team would be grabbing their order sets and then using the same, and then just adding comments like, please don't do these, but adding a sub comment, do these for this, but using that order set. So what we had the LIS system do is limit order sets according to subspecialty. And that has been a really big advantage, because certain clinics don't have access to certain order sets that don't pertain to their specimen or subspecialty. We've used LIS and blocking to our advantage to prevent some of that, because downstream it was the confusion, like, why is the breast team sending me a GI order set, but with a paragraph of comments like, please ignore all the ERPR, but do MSI panel. So we use that also as an advantage to streamline just the ordering, and this is only like the ordering part. But I just wanted to provide that feedback as well for others that might be also having those challenges there.
No, I think you made that is a great call out, because we've done the same. We are building order sets, and order actually just even orders kind of, those the parent-child orders specifically for different specialties, because of the different specimen collection sites and sources that they have, because it just streamlines their work too. And in this example, like I said, our oncologists place these orders. So we did create a standardized order set with all of the recommended, we don't reflex today. I mean, we are looking at different ways. And part of the reasons we don't reflex is we just order everything up front. And the reason we don't is because of the turnaround time issues, and we don't test in lab. And so just that communication right now with our current reference laboratory, how do we make that work and have it really be efficient for the patient? But we do have that all set up. So the orders that they should be ordering, the biomarkers that they should be ordering are in the order. They're pre-checked. If there's something they shouldn't be ordering, or that, let's say, patient has one of the markers already for some reason, they can uncheck it. And so, yeah, using that LIS to your advantage to help mitigate some of that confusion and also expedite the process. It's great. We will move over here to our bright spot number 2. And our second video, it has another problem and solution set here. So our video number 2 is Wendy Waugh, and she's the administrative director for the Cancer Services and Ambulatory Infusion Center from Southern Ohio Medical Center. And she is going to address the problem of lab ordering and how to automate the order entering process through the order set, similar to what we were just talking. So again, another really good segue into Wendy's presentation. So if we can go ahead and play that.
One of the first things we noticed was actually entering the order. We wanted a way that we could automate an order, and we could make sure that we were clear in answering whatever questions the laboratory needed to have answered to generate the order. And I didn't want that to happen with lots and lots of papers. So what I wanted was, when the physician was using the electronic health record, I wanted the physician to be able to order the laboratory test that he or she wanted. And then I wanted to automate that process to automatically go to the lab for the order. So I was able to build the order sets in our electronic health record. And when the doctor ordered that and approved that, I was able to add additional questions that the lab needed to know, like what kind of specimen does this need to be? What kinds of questions needed to be answered? And that was in an assessment format that our navigator could then pick up and make sure when she entered that in the online portal that she had the information from the physician that she needed to answer the questions related to the testing. I think everyone recognizes that precision medicine and biomarker testing and some of these lab results are extremely complicated to understand. There's a whole wide range of gene sequencing and what we call them, whether they're somatic or they are germline, is another really important aspect. So those were the complications. And again, I was extremely passionate about using the electronic health record in a meaningful way. And so what I did not like is that we were receiving these laboratory test results back in a PDF or picture format, and then trying to recover and incorporate those lab results that are truly diagnostic measures of the patient's cancer that needed to be part of their staging information, and if they're EGFR positive or KRAS or NRAS. So what I did is I created user-defined fields, discrete, so that when that result came back, again, we have a navigator who was responsible not only for incorporating that picture of the result into our EHR, but for entering any pertinent results in the specific user-defined fields. So this is complex, and it seems like we're always adding more user-defined fields as more genes are being tested for, and we're getting things that are more and more common. But I think it's critically important that in the future that I'm able to go back and run a report and say, how many EGFR positive patients do we have under treatment, or have we had since this date? And if that were just an individual record in an individual patient chart, I can never have that aggregate data that's going to be really important for the future. So talking about the lessons learned, I've really shared that, we must adopt the EHR technology and the things that our EHRs can do for us. But in every example I provided for you, we needed people that are on the people end, right? So in the very first example, I talked about the orders, and I talked about you have the provider or the physician that's doing the order, but we need that provider to answer those questions to have the most accurate information. And then a navigator, in our case, must get that assessment information to the lab. And then the lab needs to help me. So I need the laboratory technicians to communicate with me about new tests, new orders. How should I enter them as discrete fields? What does that mean? What's the difference between this test and that test? And then getting those results and getting them entered. So as much as we need to rely on technology, we have an equal amount of responsibility on the people side of things, from the physicians to the navigators to the EHR administrators, and working with the laboratory to understand what these tests are, how should we enter them, and how should we report on them. So technology, critically important, but can't use technology without the people in that component and staying that collaborative connection and understanding what we're working with.
So again, just another really great presentation from Wendy. I think she brings out a really great comment, which is the whole idea of being able to get the information not only in the EMR, but in a way that is useful to the providers, to the patients, to anybody who's providing care and follow-up. I think that is one area or another area that where we could improve really. As our order sets are set up, as I mentioned, we have an order set that most of these do. In fact, all of them go to a reference laboratory. They're coming back as discrete results. And so their own individual report in the EMR. And our providers do fine with it. They're used to it. They know where to go to look for it. But it's probably not as efficient or as comprehensive as Wendy was talking about in her experience. So I'm curious, Carla, how that looks on your side.
So right now I can sort of echo her feeling, because since we had spoken before, we were chatting before the presentation, we do have our CP, which falls, MDL and cytogenetics fall within that division. Often their results come back as a PDF. It is linked within the Epic system. However, when you link with, like, if a clinical provider is trying to look for that test, they would click there and then they would have to further click, then open the PDF to see the results. I think with CP going live, we have really expressed to the analysts that we need a link, a direct link, in order to have everything linked, because when a provider or anyone's looking at a result, they should be able to just click on that order set and then that specific test, and then the results should be populating on the right-hand side. That's a work in progress. They're not expected to go live until next fall. In the meantime, we are sort of patching some of our results. For example, like she mentioned, we do have discrete fields where texts are being entered. However, not everybody on the clinical side from all the clinics know where to look, where to find that. So in our pathology expeditors that I mentioned within my presentation, they're often the liaison between the clinicians and the pathologists. So they're often answering and just providing basically just screenshots within Epic, like, here's your results. It's right here within the addendum of this report. And so there's definitely a lot of analysts working towards making that very transparent and streamlined for everyone. But right now, that's one of the areas that we have some challenges as well.
Yeah. I think one of the things that we've struggled with, or maybe I'll just say this is my personal my personal thoughts, struggled with, is that, in a big organization like we are, and I'm sure you're in the same situation, you have business partners that you work with very closely, and they're great for 80% of the work, but maybe there's 20% of the work that you just wish it would be a little bit maybe better. And I think this is kind of one of those areas where because we send out to a reference laboratory, and for most of the clinical work, I think it's really great and it works well. And I think it's improving for the biomarker testing. But to your point, there are certain things that our reference laboratory partner doesn't perform. And so we have to send that to a different lab, like NTRAC, for example. There are certain things that we aren't able to get. So it's just really making that even more complicated when those results come back, because coming back from another lab and they look a little different. I think one of the things that I would love to be able to solve for us is being able to kind of build that case for, maybe for certain kind of tests, or maybe these niche tests, maybe we need to look at, other options for testing that actually do maybe play better with the EMR, or maybe we have a better reporting structure. I think the other thing that we haven't really talked about either is individual tests versus next-gen sequencing and panels. And not to get too deep into those weeds, but just looking at all of those things to be able to kind of expedite the results and the presentation to the clinicians in order to get care faster to the patient.
We also explored, just to chime in, the ones that we like, for example, Mayo, that's one of the ones that we send tests that are not currently offered in-house, that are kind of like one-offs. We are in the current process of doing an interface with them. So that's also another possibility. But I know with especially genetic testing, there's just so many reference labs now. You have just to provide another overview, or maybe just a suggestion for the institutions. We do have a committee that oversees send out. So in order for MD Anderson to be able to send, or a clinician to be able to send something out to a reference lab, it does have to be overseen by committee. And actually the clinician drives the the presentation and has to have reason for standard of care and what is going to be done for this patient and how many volumes and everything. They have to have everything, and then the committee will oversee it and then vote whether or not they're going to allow this test to be sent out. So that has been very helpful, because prior to having this committee sort of being the governance over what is being sent out, we did have clinicians just saying, can you send this here? Can you send, and so that has been a big improvement on our end, just to have someone sort of be the gatekeeper of what can be ordered and what can be sent out.
I think you make a really great point, and I'm glad you brought it up. We have something very similar. We only have 2 AP labs within our system, but we do this in all the different specialties where, you can have, chemistry in all of our hospital laboratories. So, and in our, our central outpatient labs. So we do have what we call technical teams for all the specialties. And we do have a reference lab technical team that helps work on some of these things and standardizing send outs and things like too. So very similar to what you've experienced. Well, we will move on to the next tab. I saved a question for this next discussion topic that came up as we were talking, Carla. So in your lab, the question really is, and for participants and Carla, for you as well, what is your priority or for improvement? I think you've shared 3 of yours very succinctly today for non-small cell lung cancer. One of the things that I noted down, you talked about your pathology expediters. Wendy talked about her navigator. There's these positions, right? And how do we, as laboratories, especially for these, what we would maybe consider non-productive, you can't really put a test behind it for budget purposes and things. Have you ever been involved in any of those conversations? Because I really do think for us, resources is one of those priorities. Like, how do we make sure that we're optimizing the resources we have, which you've talked about, but then if we identify these roles that we'd like to carve out, has your system done anything like that or justification? And if you have, do you have words of wisdom for us?
So yes, actually Path Expediters was, it's actually a position that was created just solely to handle this biomarker process, just because it boomed. And as you know, it just keeps growing and growing. And every pathology case now, I believe, has so many layers of complexity. Now pathologists have to be able to provide a biomarker designated tumor block per case, just because, and I think it also has to do with MD Anderson, just being that it's a cancer hospital. More than likely, we're going to do extensive tests. And so, yes, speaking to a position sort of like this, and then currently this position does not generate any revenue. So it was very hard for me to establish and to present it to our department and our division to emphasize the need. However, when we first launched, we started off with two Path Expediters. And I believe the position title was something else, like a clerk, and so it sort of evolved. But I did have to provide a lot of the metrics as far as increased turnaround time, and then the burden that it was placing on the additional laboratory or lab technicians that we were sort of using just to sort of patch this workflow. As they started seeing the need and they started seeing the cases and requests start increasing, certainly a lot of the clinics were in favor of increasing the staff within this area. We did get a lot of clinicians that were willing to dedicate funds towards this operation. So yes, there's definitely challenges, because I know how it is to present something that doesn't have any revenue, sort of just like an expense. But it does upstream and downstream. They're the ones that are going to be receiving, like the technical will be receiving technical charges and so forth. And then upstream would be the reimbursements of test and then the resulting. But in between, which is the Path Expeditors, there's no revenue there. Highlighting the expectancy and the expectation from the clinical team and the clinical trials team, I think really gauged and really gave me that advantage that I needed to sort of push and then really launch this area here that now everybody knows, like everybody knows who they are in the institution.
That's awesome. I hope we get to that. I hope we get to that point at someday. And I think we can, I think we will. But to your point, there's always some finesse in really being able to provide data for why those kind of, like you're saying, those non-revenue generating positions are so important. And especially when you see like the efficiencies, the other efficiencies that you're being able to build in, and just the capacity of the organization to be able to serve more patients with these added positions. So I think it's just amazing that you've been able to do that. So it's a great job. So has anyone tried to develop tracking systems for these tests, since most of them were sent out? You know what, that's a really great question. I can say in our experience, we haven't done that yet, but we plan on doing that. Again, most of ours are discrete result fields. So we are able to kind of like track what's coming back. Now, if you're trying to say like tracking them out, like just like not losing sample, like sample tracking, it's hard for us to track into a receiving lab, but we use Epic Beaker, if that's the question. We used Epic Beaker and we created special packing lists that didn't have billing attached, that allowed us to like pack a group to that send out lab, and then when we return it, we unpack it locally. But there's really no way for us to receive it, like have it shown received on the other end. As far as like data tracking, again, because we do use discrete fields, there are ways that we can track result turnaround time, and even like compliance, like how many of the patients are actually getting all the biomarkers. We just unfortunately haven't really gotten that far yet, if you're asking about result tracking. Okay, great. So the last slide in our conversation today is just to remind everyone, I know that there's a link in the chat that goes out to our action plan. And that was one of the tools that we had given away in the beginning of this project in the series, to really help folks organize their thoughts around what their problem statements were, issues have been regarding non-small cell lung cancer. And this process, is Carla is so nicely outlined in all of her workflows. And to be able to set your own goals of what you need in your institutions, what you could do, what steps you could take in order to maybe reach those goals and overcome some of those barriers, maybe anticipate them, working with your partners and your stakeholders within your organizations to move through. So really thinking back to that action plan, making sure that you're all aware of that, and also making sure everybody is aware of the resources. I know that's been linked during the series before. If it hasn't already been linked during this talk, I'll just ask Dara if you want to send it out again, but to the resource hub, that's where you can find all of the previous conversations, some of the resources with the NCCN guidelines, collection resources, and things like that. So just all those tools, plus of course this talk, and continuing to hang on with us as we move into the panel discussion, just to really, the goal is to help all of you being able to do this successfully in your laboratory. So maybe one of the last questions I'll ask while we chat is if there's anything that we haven't talked about today that either Carla and I can answer, or when we go into the panel discussion, that you'd like to hear today, or something you were hoping to get out of the conversation today that you really want us to address to fulfill that need for you. So with that, if you have any feedback for us on this method, on this talk, on this way we conducted the breakout session today, please do let us know if you enjoyed this, or if you'd like us to do more of it in future educational offerings or anything like that. We would really enjoy your feedback. Carla, did you have anything else before I turn it back over to Dara?
No, I don't. Just thank you everyone for joining.
Yes, thank you so much, both Lynette and Carla, for fantastic interactive session. And we're going to take a short break now. We are going to resume at 2:45 Central, 3:45 Eastern for our multidisciplinary panel discussion. We'll have many perspectives to be shared, so please come back at that time to join us. Thank you. We can move ahead. On today's panel, we'll hear perspectives from Lynette Pinault, Manager of Laboratory Operations and Genetic Counseling Services, Medical Laboratory and Pathology Services at Regents Hospital Health Partners, Dr. Michelle Schiller, Associate Medical Director of Genomic and Molecular Pathology Services, Path Group, and Medical Director, Cancer Genetics, Baylor Sammons Cancer Center at Path Group, Baylor University Medical Center, Dr. Nikki Sideropoulos, Medical Director of Genomic Medicine, in the Department of Pathology and Laboratory Medicine at the University of Vermont Medical Center, and Associate Professor in Pathology and Laboratory Medicine at Larner College of Medicine, University of Vermont. And Carla Valencia, Pathology Laboratory Manager at UTMB Anderson Cancer Center, as well as Wendy Waugh, Administrative Director of SOMC Cancer Services and Ambulatory Infusion at Southern Ohio Medical Center. So welcome to all the panelists. Before we jump into our discussion, we'd like to do a quick poll to check in with you. How many of you are running in-house NGS tests, and how many of you are doing send out? If you could please select, our institution runs in-house NGS tests for lung cancer. Our institution sends out. We do not perform or send out for NGS for lung cancer. I am not sure. Okay, why don't we post those replies? Gives us a sense of who is here. So we're really an even spread. This will be interesting. Thank you for your responses. You know, our goal today is whatever process is used at your institution, that you'll come away with new ideas and a fresh perspective that you can apply to strengthening communication within your working teams. So you know what to expect today. The format we're going to use, we'll be asking the panelists some prepared questions to address issues of impact to the team. And we also welcome you to submit any additional questions through the chat. So once we have panelists in view, we'll be able to get started. Wonderful, great to have everyone here. Well, let's jump in with the first question, and lots of ideas I know will come from this. Does your laboratory have a protocol or protocols in place for biomarker testing once an initial diagnosis is made? And also, how was this protocol created and approved? Who's involved in the workflow? Anyone who'd like to jump in?
Yeah, I can address that. So first of all, at Baylor in Dallas, Texas, we have a reflex staining order at the time non-small cell lung cancer is diagnosed. We don't wait to find out the stage, and it is any non-small cell lung cancer, squamous or adeno. Of course, most of those are advanced at the time the diagnosis is made anyway. And we already have at least one adjuvant indication in non-small cell lung cancer. That's only going to grow. We all know that. And, you know, I'm sure all of us on the panel have seen multiple targetable alterations found in early stage disease. Within Path Group, if we receive an order for more than one single gene test, say someone sends an order for KRAS, EGFR, BRAF, we sent a notification out in late January of this year that said anytime we receive an order like that, we are automatically going to convert it to our broad genomic panel, and stated all the different evidence that supported that. So when it comes into Path Group, that's how we run it. So there's a kind of broad approach and then also a more institutional based.
I have an interesting twist on that, because we also have a reflex test that works quite nicely for non-small cell lung cancer. And our reflex test, our first reflex test that we set up was actually for metastatic colorectal. And then the lung reflex came next. And the lung reflex is a little bit different than the first reflex because it actually reflexes for PD-L1 and genomic analysis, because the tissue was having to be shared, and how you time all of that across the different sections of the lab, you know, was a little bit of a challenge. And to standardize that and sort of set expectations around who's going to use tissue first and who gets whatever's left over is important. And for us, we found that to be important. So we set it up such that since the tissue is in anatomic pathology at the time of morphologic diagnosis, that we knew they really can only use, they're limited in what they can use in terms of PD-L1 being done on formalin-fixed paraffin-embedded tissue, whereas genomics is validated for us across not only FFPE, but all forms of non-cell block cytology as well. So we can we have very low quantity not sufficient rates because of that type of validation. And so we were able to be highly successful without risking, not leaving enough for PD-L1. And we've been doing it that way for a while. But what's interesting with our group is our lung specialists, at least our more senior one, is not keen necessarily on the reflex. Actually, a lot of pushback on implementing the reflex in early stage lung cancer. I would have loved to have done what Michelle is doing. I think it simplifies workflow for all. So if there is not an indication right now that it's advanced, then they don't implement the reflex. They're increasingly ordering the reflex just as they do in immunohistochemistry, more so as time passes. But in the meantime, if they don't order a reflex, there is now sort of an informatics pathway that was built out that those cases are sort of flagged on the weekly multidisciplinary team meeting, and there are decisions being made so they're not falling through the cracks until a patient comes back later and they said, oh, we wish we could have ordered that. So even though the order is a little bit delayed for the patients who are seen as having early stage disease and the reflex wasn't ordered, at least now there's transparency at a weekly multidisciplinary meeting on who was ordered and who wasn't. So we're having really good success with that as well. So that's our little caveat that we have based on anatomic pathology, giving pushback to the reflex for early stage.
And if I can just chime in, so that's the section, the third of the responses that do testing in-house. So I'll sort of represent the other third or another third of the responses that actually do their tests outside of their organization. So we would send our test results out and we don't have a reflex. So very different from what the two of you described, but not so different in that what happens is it does come early to the multidisciplinary tumor board, and that is discussed stage at that time, and then it is ordered. So it doesn't necessarily wait for the oncologist to see the patient, but as soon as it's discussed in tumor board and it's decided whether it's early stage or late stage, then the navigator can go ahead and start that process and get that going.
So a question for you, after that sign out is done in that particular instance and a decision is made at MDC, is the case then, does the AP staff have to go back, pull a case, bring it to an anatomic pathologist to sort of say, oh, well, this is the best part of it to send out? And if so, how are you accounting for that pathologist's time? Because I have found the send out companies are leveraging the fact that they're using the pathologists at those local organizations, and yet they're not being reimbursed somehow for that activity.
I totally am with you. There is no reimbursement. We are
Right.
absolutely coming back to the anatomic pathologist. And here's the other thing. So we, as an organization that has no financial, we're not going to be collecting anything, we're not going to be doing anything, are working on the prior auth, we're working on the financial forms, we're doing all of the things for the company to get paid. So interesting, great question. And it's tough, but it's obviously necessary for patients. But I think when you're in the small rural setting, as I represent, and it just becomes more complex and takes more time.
So I think also, Nikki, if you don't mind sharing some of the barriers that you're meeting, what the clinicians are stating are their reasons why they don't want a reflex order. I think that might be helpful to the attendees today because they likely might be having some of the same resistance.
You mean in terms of applying the reflex to the early stage?
Well, yes. Yeah.
Yeah. I mean, it was simply a matter of, what stage. And I think it was simply from our most senior lung pathologist. And there was no convincing her that this was a cost-effective thing to be doing, and despite the argument of the complexity that exists in the workflows to do it when it is right, which is the majority of the time. So, I think as I believe, the ADORA trial came out, and the implications for, EGFR testing in early stage disease, that, we brought that up. And that's when, she was more amenable to implementing this sort of backup, this catch of the cases that might be earlier stage where the reflex wasn't placed. So it was really a cost effectiveness in her mind that there was no role to do an NGS based panel, which is how we do our testing here. We don't have single gene testing. So that was what it came down to, unfortunately. Otherwise, it's been quite well received. Our turnaround times are fantastic. Everything's been standardized. And the most important thing is it really creates a sort of equitable access to genomic analysis. You don't have to advocate for that or hope that someone along the pathway remembers to order it.
Wonderful. I love the back and forth. Keep that going. You know the questions to ask one another. The next question probably pertains to all of you. Who determines what biomarkers are ordered once the diagnosis of NSCLC is made?
So we're doing full panel NGS when it's later stage. We're doing a limited panel when it's early stage. So we're actually using two different companies, one for the NGS full panel and then another company for the early stage, just targeted testing.
So we actually have an order panel or order set that we've put together, and we have a multidisciplinary group between oncology and pathology, and actually interventional radiology works with us a little bit too, to review some of this. And it all started, I've talked about this before, it started as we started bringing in screening, lung cancer screening into our programs. And so that's kind of how this team developed and kind of evolved over time. And so we have the order sets that are agreed upon, and we use NCCN guidelines to help build those out. And if something else new comes up or if it hasn't quite hit the guidelines yet, that group will be the one that'll have the conversation, decide, is it going to hit the order panel or not? We do it a little bit different than Dr. Sideropoulos' group when we're not doing next-gen sequencing for everything. We do have individual orders, right or wrong. We are looking at different ways to do that. Part of it is kind of limitations that we currently have with our send-out partners, because we're like you, Wendy, where we're sending everything out. Right now, we don't do any of that testing in-house today. But again, we're constantly evaluating all of that.
We used to have where we run DNA and RNA in parallel for next generation sequencing. And there used to be, let's say as an example, colorectal and this was before the agnostic tumor biomarkers came into play. Before that was really a thing, we had set it up where what would come into us was something that we called a request for genomic analysis. And all of our molecular pathologists staffing our lab are also trained in anatomic pathology. So when we receive the order in our lab, we're able to then go into a case, request whatever assets we want. And here we usually use surgical and cyto. We request those, they're delivered to us from anatomic pathology, and we set sort of a 2 business day kind of turnaround expectation to get those here. So there was no guesswork involved, and we could sort of monitor making sure that things were coming in a timely fashion. And then we would look at a case. And this was sort of to track how much time we were going to be spending sort of looking into a case, pulling certain, requesting certain material, looking at it under the microscope. The part that I raised with Wendy, right? Like, how are you tracking that? Because that wasn't being done before we got here. And the pathologists were just like, oh my gosh, this is just increasing and it's taking up so much of our time. But no one had a way to track it and make the business case that, oh, we need another person or we need to hire some, So basically we set that up. And when we look at the tissue, we do that triage and say, yep, in fact, this is something that should be run as a colorectal. We don't need to run RNA on this. We're going to run DNA only on this. And we are the ones who would then officially place the order for what we call gene panel solid tumor. If it, for some reason, it's a lung cancer, we're going to run it as a lung. We need to run the DNA and RNA. Again, marking our time point and all of our work in terms of assessing this request, assessing the tissue, and making the decision as to what testing was appropriate. We would then place the official order to do, let's say, gene panel non-small cell lung cancer. With the tumor agnostic biomarkers, I think we really are moving now to sort of run it all on every case. That's where we are now. But we still have that request for genomic analysis portion. And so we're able to sort of track how much time that sort of upfront, I call it AP genomics, takes. And we've taken that over from our anatomic pathologists, and they're thrilled. They're happy.
Would anyone else like to jump in on this question?
Well, I just will also offer kind of what Dr. Sideropoulos just mentioned in terms of, we saw yet another pan-tumor indication land a week ago, Wednesday. So I think it's kind of clear where the roadmap's going. For those attending today, there are several other pan-tumor indications in the pipeline. So we're going to continue to see this, as well as a lot of trials in the adjuvant space. So those are just food for thought as you continue to take on these conversations at your local institutions.
Wonderful. Well, let's move to the next question, which is, how are biomarker results communicated to the ordering provider through EMR, single report, separate reports, fax? Whoever would like to jump in.
Ours is since we are now in the Epic Beaker build, results are communicated via InBasket to the authorizing provider, and if there's a collaborating pathologist, they're also sent a notification. They're able to find that in chart review. As far as like reference testing or send outs, they usually send them to the initial authorizing provider, which would be the clinician, and then we also upload them to OnBase. So anyone else within the Epic system is able to view the results.
We have we transitioned painfully, I will say, in some ways to Beaker as well. But in the end, I do feel like the build was difficult, because their molecular module really didn't meet the needs of a NGS based laboratory, which is what we are. But we did create a workflow that met our needs, and so we're all on one system. That's very helpful. When we do sign out, we use a send out bioinformatics and reporting company. So we sign out in a virtual instance, if you will. And then that report, we have a VPN tunnel where that report comes back into Epic, and it files in Epic, and we use the InBasket feature. And we also created, how they have a results tree in Beaker. In Epic. Beaker is just a lab module. And so things were just getting filed into this other category. And I thought, that's nonsense. Like, this is actually a thing, molecular pathology, and it's only increasing. So it was an uphill battle, but we actually have a molecular pathology section now. So everyone can look in and see that was done, and that's there. And, we certainly have a smaller shop, if you will. So we do tend to communicate with physicians also using the staff message feature. If things fail, we let them kind of know right away. We communicate certain aspects about cases that are necessary. If there's a critical result, we staff message them on that. And so it's been nice, ultimately, having made the transition.
So again, I'll come in with a little bit different angle since we have outside results. So we have set up a portal with both of the companies that we're working with. So we'll do an electronic order, and then we receive the results electronically. So the lung navigator is the one who is actually notified that the result is back. So the lung navigator will actually go download the report and set it as review required for the ordering physician or physicians. But when that comes back, it's a downloaded PDF or picture, right? So obviously that's great for the clinician to review, but I also really wanted to know, well, how many positives of this do we have? And what do we have when we're going to look at aggregate data? Because I think if we're going to make decisions later or need to go back, you don't want to have to go back and see who's all the people that we ordered and shuffle through papers or shuffle through online pages. So we did create discrete fields for the NGS testing, and we are specifically typing in those fields. So the navigator does that, whatever deletion, whatever abnormality, and so that we can pull those results in aggregate for the future. Because again, we know this is going to really be impactful in the future. And what we find today may not be treatable, right? But what it could be in the future. So that's a little bit different, I think, again.
So is someone monitoring and going back and doing regular lookbacks at the patients and their variants and then redoing interpretations to say, oh, well, they have this mutation, they're still alive, it was a VUS then, or a variant of insignificance then, but now it's actually a biomarker that has a targeted therapy and they're still alive, so let's reach out to the oncologist and let them know. Are you guys doing that with the
We do get notifications when there's updates for those variants of unknown significance, and we get updates that says, hey, might want to relook at this, you might want to, so that kind of comes from the company. And yes, again, it comes from the navigator and then it's kind of picked back up and brought forward. Yes.
Well, let's look at the next question related to data points. What data points do you track for turnaround time trends in your pathology workflows?
So we're trying to consistently improve our turnaround time, and this would, as you guys have mentioned, this has really increased our workload, and also the interest amongst clinics has been just rapidly increasing over the last couple of years. So we're constantly monitoring the time the order was placed, and then it would be the end time of either a series of IHCs or FISH or MDL at the time of result. So we try to capture the whole, everything from the beginning to the end, and then stay within a certain established metric that we have within the institution. We are not there yet for all subspecialties, but we're definitely improving, especially for our thoracic and our neuropathology.
I have a related question actually for Wendy, because I know that you do send out, and we do as well, and it impacts turnaround time. It's not necessarily a turnaround time variable directly, but one of the questions that has come up in some of these conversations is tracking QNS when it comes to certain biomarkers and how that relates when you're sending out and turnaround time. Do you have it? We have not found a great way to do this. I'm curious to see if you do it and if you found any improvements or anything in that.
Actually, I get a quarterly report from the company that we are working with, and it will give me the number that we ordered, the number of QNS, and it actually will tell us the days. So it has the turnaround time in terms of days from test received to test result received and those kinds of things. So I have quite a few statistics coming from at least one of the companies that we're working with. And that is the company that we're doing the full panel NGS spectrum testing. So it is the majority of our testing.
Have you learned anything from that data that you've been able to bring back and to do improvements with the workflow?
Initially, yes. Initially, we learned that we needed to get a navigator involved, because what we found is that the physician was receiving the results, for example, but may or may not be checking to see, when is this patient coming? How does it impact their care? Do I need to move the appointment up? Those kinds of things. So I think what we learned is that certainly the navigator, number one, if she hasn't received a result, she's looking for it. She's asking questions. She's doing things. She's able to react on a QNS rather quickly. You know, she's also, as soon as she receives the result, she's doing a quick review. She's obviously looking at the result, because I told you that she's actually typing them into the unique fields. So then she's looking in the system, when's the next appointment, saying, okay, maybe we need to move this appointment up. So what can we do in that regard? So yeah, there's definitely the human component of the navigator, particularly with this outside testing, I think is critical.
I feel like you need another navigator.
Yeah. Well, the more testing that we're going to be doing, right? And again, this is a lung navigator. So how is it going to be applied to other sites and that sort of thing as well? So I think in the future, I don't know how sustainable this is with an outside laboratory and doing some of these things, to you guys' point, in terms of pathology and the time and the work and what we need to do to get the patient result to start treatment and keep ongoing treatment.
So the turnaround time variables that we monitor are QNS. And then, but for turnaround time, we monitor the moment that the specimen is received. Then we monitor how long it takes to get to slide review if we don't already have an H&E stain slide, if it's not internal. And if it's internal, that's also a very short window. So there is a different timetable there, so to speak. Then we monitor the time to DNA isolation, time to the sequencer. And we also then have a long time to when the data comes off the sequencer, time to report writing, and then time to completion of the report. So we are monitoring multiple steps along the process. So that's what, to answer that question. I also wanted to follow my answer with a question to Wendy as to how you got the lung navigator. I think that's a curiosity that I have, and I'm not sure if others share that same curiosity.
So, Dr. Schiller, we started actually with our lung navigator in the screening program. So I'm not sure that our program started or is traditional, but we got the lung navigator to support the screening program. And as the screening program grew, then we implemented an incidental program in which we were looking at the incidental lung nodules. And we were able to get another lung navigator for that. And here's what we did. We literally took 100 patients before we had the navigator looking at them. And we said, what is happening with these 100 patients? So we did sort of a retrospective study, all right? And essentially 50% of those incidental lung nodules were going away from our organization. So we made the case to add the navigator simply to make sure that that incidental lung nodule, we called them, we got them an appointment, we got them quickly into the pulmonologist so that we could work that up. So we made that case on that. And then this NGS testing has just kind of been put in their lap, I would say. So they existed because of the screening and the incidental program.
So I think we monitor a lot of the same, all the different, like I think of NGS, one of the first educational points here, because we started this lab from nothing, was, it's not just the sequencer you need to have in-house to do NGS, right? NGS is a workflow. And what does that consist of? So if you understand the workflow, you can set up sort of the pieces, the time pieces that you can monitor to make sure your overall turnaround time stays within whatever your goal is. The one thing I think that's really interesting to monitor for those attendees who maybe are thinking about a reflex is, what I call the time to initiation. So when does a case after morphologic diagnosis ultimately get moved over to the molecular sphere? And it's quite a wide variety. You could see a lot of variation in terms of the time to initiate sort of a molecular workup prior to having a reflex. So once you have the reflex, the cases that should be getting reflexed, and you look at those and you say, okay, 100% of the time it's getting ordered like same day as the morphologic diagnosis, and you kick off the process. So there's a lot of fat that you can trim out of the turnaround time by tightening that up. And so we sort of look at that from time to time, and it's working quite well. So it doesn't only shore up equitable access for patients that move through the system as their tissue is moving through that process, it also tightens up the time to initiate the appropriate ancillary testing.
Great. Let's move on to, are you measuring per guideline recommendations? And how are you creating processes to optimize turnaround time for either both reference laboratory or internal biomarker testing?
So I just have a question in terms of clarification. When you say, are you measuring per guideline recommendations, what exactly? I don't think I understand what you're asking.
Would anyone else like to address that? Would it be the NCCN guidelines or
it's just unclear if they mean our interpretation cutoffs, I think is probably what Dr. Sideropoulos is getting at. Like, are we measuring per guidelines of percent tumor, of limit of detection, of actual biomarkers? For our brains, it's a very robust question. So we need a little more specificity.
I think take it wherever it is most interesting for you. Which aspect of the recommendation do you measure?
Okay, I'll go with Dr. Sideropoulos first, since she was going to take a stab at it.
I don't know. I mean, I'm thinking, okay, do you mean like treatment guideline or like biomarker recommendations based on the NCCN? Like, are you making those interpretations, and then are they being used for care in time before someone initiates therapy? That's sort of where my mind also went with that question. We are kind of periodically checking, and we certainly, with Beaker and Epic and being all in that same space, we are able to see the encounter that the patient is going to have with the medical oncologist. And so we are able to turn our report around in time, 100% of the time to date, before that encounter happens. And because of our staff messaging, we are getting acknowledgement that the oncologists are seeing the reports before they're talking to the patient. I'm not doing the micromanagement of saying, geez, there's an EGFR mutation. Did they use the right therapy? I haven't gone there. There are some people across the country who have, but I have not done that.
Can I jump in here and say my interpretation of that, just kind of, again, coming from a different perspective, is I think both of you are doing some reflex testing, right? So we did some audits of NCCN guidelines to see when our oncologists were ordering. So we weren't necessarily ordering, even though it would be recommended for late stage. If for whatever reason the patient said, no, I don't want to have therapy, or maybe they elected hospice, and early on, we didn't find early adoption at a community rural hospital 100% of the time of even doing the testing. And I would say that if I look now, we still wouldn't be 100%. So that's kind of my interpretation of the guideline. Like, we should be doing NGS testing at late stage. You guys are probably doing that because you're reflexing. But if you're waiting on the oncologist to even order it, it might not happen.
If this is helpful, I just received clarification on the question. The question really is addressing, are you measuring adherence to guidelines to which genes you are testing? I think that was the gist of the question.
Right. That's actually exactly where I was going to go with that, Tara. So, so it's probably more for Dr. Sideropoulos, I know, because you are doing your own, you're doing a lot of NGS, obviously. So do you have a set, like, we're going to do the NCCN and this is what we're doing? Or has your group looked at those and said, no, we're only going to do a subset, or we're actually going to do more? And if you're expanding your panel, like, who's making those decisions, kind of thing?
Yeah, right. I mean, the panel that we're transitioning to imminently, and I'm sure Michelle's already there, but hundreds of genes, DNA and RNA in parallel. And I think our current vision for bringing this live would certainly be, at a minimum, doing medical interpretation of all the NCCN based biomarker recommendations, probably the emerging biomarkers, and then stating what else is there, but not necessarily doing interpretive work. First of all, it's not paid for as a professional fee. There's the reality of being able to do, I think, medical grade interpretation of all those variants once your panel is that big. So there's also another lab we work closely with, and they're doing a similar interpretation. So you will see a similar practice. So you will see full interpretation of the genes that are at least at that NCCN level and the emerging biomarkers in the space. So I think we're meeting those guidelines, but the panel's really large because it allows you to do things like MSI and TMB, and it kind of has to be that big to do TMB. So there's a lot of genes we're not going to really report on, but the data is always there, and we could certainly field any clinical request to say, I need to take this a step further. I really need to look into trials. So that's part of the workflow too, is that our oncologists know they can ask, and we could do a much deeper dive if necessary.
Thank you for that. We're near the end of our time, and it would be great if you could each leave us with a suggestion in regards to ordering and turnaround time that participants could take away from today's session. Is there something in mind, and what would that be? An actionable step that could be taken?
Set up the reflex. Even if you're sending it out, set up the reflex. Empower the pathologist, the anatomic pathologist, to be the ones. They are in that driver's seat. If they have a meeting in a multidisciplinary setting and you say, okay, guys, it's the right thing to be doing this. Do we all agree? Vote yes, bring it through compliance and set up the reflex.
I
think
agree.
that's a
And
great
but I got to
way
talk
forward.
before we go to the 5 things. So if we set up the reflex, help me. This is my question. Who gets the results? How do we know who the patient is? Okay, Michelle, tell me. You guys. So then what happens? The pathologists get the results. Where do they go for the patient or for application when you reflex?
Yeah, well, so I would say this way, we get it, but then also we'll have CC, blah, 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 whomever. So say it's a lung biopsy, the interventionalist, the oncologist may not yet be determined,
Yeah,
but
so
at least a clinical provider is tagged. Or with our thyroid, the ordering pathologist, and then often we know which endocrinologist the order originated from, et cetera.
Okay.
So they're CC'd, but to kind of draw from what Dr. Sideropoulos was saying, this is our house and nobody comes into our house. We need to own it. We need to give them direction because we can put context and meaning to this like no one else. And I promise if we don't, they're going to just go somewhere else. So this is our house, that Flo Rida song.
I love it. I love it. I love it so much. And that's how we learn. So very good. Sorry, I had to throw that in there. I couldn't not.
Love it.
Yeah.
Even though I love that it's our house, we also have to play in the playground, right? So I think being able to bring everybody in when you're building the reflex or building whatever that relationship is, I mean, we want to get there. Our first step was actually getting an order panel for all of the NCCN guidelines that we could all agree on that our oncologists order, right? So being able to connect with our pulmonology team to make sure the acquisition is what we need with our Rose team, and then making sure the orders are being placed from oncology, at least for us today. Or however that looks for you. And then just, being able to continually have those conversations with those other clinical partners to make sure we're continuing to improve and continuing the dialogue as things get more complex, as Dr. Sideropoulos and Schiller mentioned.
I also agree with the panel. The feedback I would give is also echoing being an active cheerleader, I guess, for reflex. We have been successful at doing that with neuro-onc and then neuropathology. We're currently undergoing a pilot study with thoracic to see if we could also get this going, but it's definitely the key would be communication between the clinical teams and then the pathologists, and then establishing that relationship there, then obviously a procedure, standard operating procedure, followed by a pilot study to work out all those kinks in the work. I know it takes a lot of collaboration and I know that everybody's very busy, but like you mentioned earlier, highlighting that this will benefit the patient or being able to enroll patient early in a clinical study that they qualify for is what we are striving for. So definitely would be communication, collaboration, and then organization at the end. Thank you.
Yeah, and I think I would add too, and we talked about this earlier, being able to track some data, Wendy in particular, around how much your anatomic pathologists, how much time they're spending, probably increasingly so, and all your staff to manage
just
all
this
those
one
things.
lab just offered us like $25 for every send out we do or something.
No,
just
thank you.
No, I know, I'm just telling you. That's funny stuff.
Yeah, no, thank you. Put together an assessment and send it to them and say you need to meet this. So yeah, I think being able to track that is really helpful because it does take a lot of time. You know that you're living it.
Well, we are out of time, but I want to thank you all panelists for such a robust discussion, really modeling what it is to communicate and work together in this reflex example. As we're out of time, we're at the end of the conference. So again, thank you for sharing your perspectives. And we want to thank you as well as all participants for tuning in today. Please take 30 seconds to complete the survey, which will appear on your screen at the end of the event. It helps shape our future education events. And also, please join the discussion in the Facebook group as we hope to continue to build community around issues in the lab. Thanks again, and this concludes the virtual summit.